This conference will now be recorded.
It's Tuesday, March 11th, 2025. Welcome to the AnCan virtual support meeting for high-risk, recurrent, and advanced prostate cancer. Thank you. Thank you all for joining. I'm moderator Ben Nathanson. I'm joined by moderators Len Sierra, John Antonucci, and Rick Davis, the founder of AnCan. Although we talk medical issues, we don't give medical advice. Funding for this meeting comes in part from companies Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, and Blue Earth Diagnostics. We continue to, there's no compulsion on our part to praise these guys because they sponsor us. We are free to speak as we feel. So let's begin. We have new participants tonight. Conversations with newcomers lead off our meetings. Boyd, welcome. Appreciate your coming. I'll ask a few questions, and then the floor will be yours. This is a kind of a superfluous question, but I'll ask it anyway. Where do you live?
Regina, Saskatchewan, in the middle of the Canadian prairies.
How old were you when you were diagnosed?
64.
And what year was that?
2019.
What led you to? I'm sorry. How old are you now? I could have done the math, but
69.
Okay. What led you to think you had prostate cancer?
Nothing. It was just a routine checkup with our GP, and she just checked off the PSA test just because I never had it done, and I had no symptoms or anything. So that's kind of started the ball rolling.
What was your PSA?
Originally is 6.5 or 6.3. I can't remember, one of the two.
And what did you do next?
Repeated it in 3 months. So the first one was in February of 2019. Second one was in May of 2019. Another high reading. I think it was 106.3 and 106.5. I can't remember which order they were in. And so then she referred me to a urologist, did a whole battery of tests, and early July of 2019 is when I had to confirm that I had prostate cancer. And at that time, my PSA was up to 12.5.
You had an MRI?
Yeah, MRI and CT and bone scan. No MRI, just CT and bone scan.
Did they do biopsy?
Yes, I did. There are 12 samples.
But no MRI.
No.
And what was your Gleason score?
He said it was a high 7. They treated it as an 8 because he said it's virtually an 8, and I don't remember which number was first, 4 or 3. I don't recall.
Did you and what did you do then? Did you have a prostatectomy?
Yeah, in November 2019, I had a radical prostatectomy, and from then on, my PSA dropped to negliger, undetectable, until about a year and a half ago.
So, what are you doing now?
Right now, I'm going to start hormone therapy April 22nd. I got my first shot of Eligard.
Are you going to be taking any other drug with the Eligard?
Yeah, there's another oral medication, but I can't remember what it's called. I got to take that along with it to begin with. I think it was a 10-day regime of the oral med, and then just the injection.
So Casodex or bicalutamide, does that ring a bell?
The B one does, yes.
Okay. So your doctor's not talking about taking. So that drug is a short-term drug, but he's not talking, or she is not talking about taking one longer term, along with the Lupron, a drug like enzalutamide, abiraterone.
Not to begin with, no.
I did not ask, where are you being treated?
Oh, we have a cancer clinic here in the city, in Regina here. So.
And who's going to be giving you these drugs? This will still be the urologist?
No, no, I'm seeing a radiation oncologist originally, and then so now he's going to take over my care, and he's ordered the meds.
Oh, I'm sorry. So what you're doing is you're going to get salvage radiation for your PSA
Uh,
rise.
I can't do that because I have colitis, so he doesn't want to do radiation yet. He wants to try this as a first treatment because he wants to go with least invasive and then go from there.
Hmm. So I'm not clear what he's trying to shrink the size of the lesions this way, or
Uh, yes, yeah, exactly. Stop the cell growth is my understanding. Yeah.
do you know where he plans to irradiate? They have some choices in this.
We haven't talked about that yet because he wants to leave the radiation as a last resort because he doesn't want to damage any of my bowel or colon any more than it is. So
So his thinking is that if the PSA responds I'm sorry, if your PSA responds to the Eligard, that you won't get radiation.
that's correct. Yes. Yeah.
So you might stay on Eligard indefinitely,
Yeah. Could be. Could be. Yeah. So
and
you're
it
going.
would be I'm sorry.
Okay. You're going to use this course for a year and then we'll revisit what we're going to do.
Okay, I think people will have some questions about that. Um, so have you had any genetic testing?
No. No.
Okay. Do you have a family history?
Yes.
Cancer?
Yeah. Well, my mother had breast cancer, so
Did you weigh prostatectomy versus radiation? Was it an easy choice?
for me it was. Yeah. Yeah. Just because my colitis there and the research I did, and my wife and kids are all nurses, so I had lots of input.
Yeah, yeah. Rick, am I missing anything?
What's your current PSA before you start the bicalutamide and the Lupron?
Point 4.
0.4. And it's gotten to 0.4 over the last 18 months, is that right?
And it's been zero point 0.4 for the last 6 months.
Okay. So you're pretty stable.
Yeah.
Have you had any discussions about a PSMA
Yes.
scan?
And he's reluctant yet because he said didn't think it'd be that beneficial for me at this point.
Well, I think we would, if it were me, I'd want to know because we want to know where that cancer is because maybe if it's got out of the capsule, we may be able to shoot it with radiation and maybe nowhere near your colon, and that could be another way to go, at least initially, since you're so stable. Now, we get the Canadian system. We know it's much, much harder to get any type of treatment. But I think you and your wife can go in and argue with him that you would like that PSMA scan now because you don't, you've been very stable for the last 6 months, and maybe there might be a spot that we could treat and then we can defer the radiation. And that would give you a better quality of life.
Yeah, I agree. So I think maybe I'll take your advice, and I don't get to see the oncologist until June, but I'll definitely be posing that argument to him.
Well, the thing is, you need to pose it to him before you start taking the Lupron and the bicalutamide.
Oh, okay.
I mean, once you started taking the Lupron and the bicalutamide, he's going to say, "Oh, you seem to be doing quite well. So, what's the difference?"
Mm-hmm.
On the other hand, if you go in and you ask him right now and say, "I don't really want to do this if I don't have to, and I'm pretty stable, and my disease didn't show, so, why don't we do a PSMA scan, see where it is?" and maybe that's another way to go instead of stuffing me with this hormone therapy.
Yeah, yeah. It's food for thought, but like I said, that's pretty difficult to get it because up until recently, there's only been 2 in the whole country, so it's been tough to get treatments. But I'll definitely follow up on it.
Um, I mean, I think we're aware of more than 2. I have to be honest with you.
Yeah. Now there is, yes. Yeah.
But I mean, even we've been working with people from Canada for a long time,
Mhm.
and about 4 or 5 years ago, it was real hard. There was one machine on the West Coast, and there was a machine in Montreal.
Mhm.
But now I think it's much more prevalent.
Yeah. No, now there is, yes. Yeah.
So, so that I mean, I think that that's probably those are the things that come to my mind. Do you
Mhm.
want to throw it open, Ben?
So Wes has a question.
Well, just a question you might ask your MD. Where is my cancer? Following up on Rick's point. I bet he doesn't know.
All they're saying is somewhere in the prostate bed. That's all. That's all the information I get.
But why would he know that?
How does he know that?
I have no idea. I'm not a doctor, so I don't know.
Well, I think you've got to ask him, how do you know that? I mean, if they've done, have they done any CT or bone scans since your disease came back?
Yeah, I just had it done in January. I had bone scan and CT of head, stomach, chest, and pelvic.
And what did they show?
Nothing.
Okay. So if they showed nothing, and um, I that's my point about the PSMA and Wes's point. We don't know if it's in the prostate bed. It could be in a lymph node. It could be you could have a bone metastasis.
Mhm. Yeah,
That's that doesn't show because the technetium 99 is not going to show what a PSMA scan shows.
yeah, yeah. No, I don't disagree with you. I just don't know where to go to get it done. That's all. So
Well, what we try to do here, and it's to just to empower you so you can sit with your
mhm.
radiation oncologist
Yeah.
and you can have a discussion with him and talk with him rather than him just talking at you and saying this is what I'm going to do.
Mhm.
and
Okay.
and I think the best way to come at that is nobody wants to be on hormone therapy. I think every man in this room has been or is about to be on hormone therapy, and nobody wants to be in it, especially for an elongated period of time.
Mhm.
So if we can manage your disease without putting you on hormone therapy, it's a better outcome.
Yeah.
And
Mhm.
the first step in figuring that out is to get an accurate scan, and the CT scan, I don't know what he did it with. The bone scan was most likely a technetium scan. They're not going to give you that same level of detail. Anyway, I don't want to talk too much.
Mhm.
Ben, you've got people with their hands up. The one thing I just want to say to everybody is whatever it is you want to say, just consider that Boyd is in Canada. So what might be true for us here in the United States is not automatically true for his situation. The access to a lot of treatments and a lot of standard procedures is just not the same, unfortunately.
Stan S., you wanted to weigh in.
Yeah, just a quick question. Have you had a prostate MRI with or without contrast since the recurrence?
No, no, I haven't. No.
The reason I ask is your story is quite similar to mine.
Mhm.
I'm currently running at a zero point 0.6, but 2.5 years ago is when I first hit a biochemical recurrence level on on PSA, and they did a prostate MRI with and without contrast and identified an enhancing nodule in the prostate bed. which I've been following, and it's my PSA currently is up to 0.57, and there's consideration being given to number one, radiation confined primarily to that area, but we're also considering focal therapy. I've been offered typical radiation and hormone therapy. I've been deferring that for 2.5 years, but and I've had 4 PSMA PET scans. They're all negative as the PSA has slowly risen,
Hey,
and the
I'm,
nodule has stayed approximately the same size.
I think Ben wants to get in.
I mean,
Stan.
we
Go ahead.
we asked you if you wanted time tonight, Stan. Um, I mean, we're talking right now to somebody else.
We're happy to give you time, Stan, if you'd like to. If you'd like to talk, but what we try not to do is divert a conversation into our own situation whilst we're talking to somebody else. But we can put you on the list and we can try and get to you later. We'd love to talk to you about your situation.
Now, my question was whether or not he had had a prostate MRI.
We got it. Yep. And the answer to that is
No.
no. So again, there's that's another thing to bring up with your doc. You're aware of gents who have had MRIs to the prostate with contrast, and things have been seen. But I think, and we know that that's something you can get. Dr. Alfredo has put a link in the chat, which I suspect may be a location to get a PSMA. The problem is that Alfredo, as you probably know, is it can be there, but you can't get to it without the gatekeeper giving you permission. And that, this is
Absolutely. Yeah.
This is the Canadian system. So I think there is a PSMA scan available to you close by. The question is, how do we engineer the situation? And I would say quality of life, stressing quality of life.
Okay.
What did you want to say?
Yes, Boyd, you said your PSA was stable at 0.6, I think, for 6 months. What happened before that? Did it just pop up as 0.6, or was it over a period of time? Did it inch up little by little to 0.6?
Yeah, it went up, little by little. It started out, I think it was September of 2023, I think it was. It started up to 0.1, and then it went up steadily up till it peaked at 0.4 6 months ago.
Okay. And who was monitoring you at that time? Your urologist?
Yes, yeah, urologist, yeah.
Well, I think he should have passed you on to a radiation oncologist earlier, but at least in the United States, I don't know what practices in Canada and the United States, we like to do salvage radiation therapy between 0.15 and 0.25.
Yeah. Well, up here they wouldn't entertain that to 0.4. So.
Yeah. Okay. I was just curious.
Yeah.
Gary Peters?
Boyd, before you get too far down the road of taking the hormone therapy, it might also be helpful if you could get what's called a DEXA scan and also a testosterone test. If nothing else, it will give you a benchmark for future exams you might have to determine your bone health and whether you should have a bone strengthener. Well,
Hang on.
and at some point, you're probably going to want to try to recover your testosterone, and it's nice to know what you started with.
Yeah, I did have a testosterone test done, and I don't remember the number. It was above the normal range, but I don't recall what the exact numbers were now.
Great.
Yeah.
I didn't do that, and I wish I had.
Okay. Yeah, that's been done, but the other one hasn't. So.
So, do you have any more questions, Boyd? Because we're okay. Well, thank you. Yeah, get a get a get a PSMA scan if you possibly
Yeah,
can.
I've been making notes here, so yes, I will.
Thank you very much.
Welcome to group, Boyd.
Thank you.
Do we? Are you receiving reminders? We just like to make sure you're on list so we can send out reminders to you, Boyd.
Yeah, I got one for this meeting, so I would assume that I'm on the.
Then you're on the list. Yeah, great.
Thank you.
Thank you, Raymond S. So you're another new guy,
Yes.
and you heard the questions. Appreciate your coming. Where do you live? Again, so I see it on the screen, but for the record.
I live in Connecticut.
And how old were you when you were diagnosed?
Just before my 65th birthday,
What year was that?
3 months ago.
What led you to think you had prostate cancer?
Well, my father had prostate cancer and he died of it. And that was 10 years ago. And he was 20 years old, 30 years older than I am. So he died of it at 85. And I kind of knew prostate cancer was going to be a possibility. So I kept my annual physicals. I kept asking, making sure the PSAs were taken every year. And they were around 2.6 for years, 2.5, 2.6, just kind of creeping up. And then maybe a year or two ago, it must have been 2 years ago, I can't remember, my doctor referred me to a urologist. He wanted to hand me off to them so we could monitor it more closely, because I felt my doctor wasn't really there when I needed him. So that was my general direction. So I went to your urologist. We took PSAs twice a year, and then it spiked up to 3.8, and that was last November. And the doctor said, urologist said, I'd like to have you do an MRI. We took an MRI. He said there's something. After the MRI, he saw something he didn't like, so we did a biopsy. Mm-hmm. And we did 7 samples on the biopsy, and they all pretty much were at 3.4s for the most part. So they're pretty consistent. And then after that, I was bouncing around. I hooked up. My physical therapist knew this guy, Stuart, who maybe some of you people know in the room. He's active in AnCan, and he told me all about this group. And so I was talking to him for a while, and ended up talking to 2 different doctors. They referred me to a radiation oncologist. And then I had and this is I have a question about, I had a PET scan, and and this is only a couple of weeks ago. After the PET scan, it came back that it had metastasized to the bone, which is exactly what my father had. So then at that point, the doctor says, I need to hand you off to a medical oncologist. And so I'm still waiting to see the medical oncologist. Every time I make an appointment with a doctor, it seems like it's weeks. So I just want to start treatment sooner than later. That's just where my mindset's at right now. So
It really sucks. You were extra cautious, and you went in with a 3.8, which is still, on this side of the 4. And
yeah. And I forgot to tell you, so we had a decipher test as well. after I had just before the PET scan, I had the Decipher test, and it came in at a 0.92, which is pretty high,
Mm-hmm.
I think.
Mm-hmm.
I mean, judging by the graph I'm
Mm-hmm.
looking at, I'm way up
Mm-hmm.
there.
Mm-hmm.
So, so yeah, I had a 3.8, and everybody's like, "Oh, it's not a big deal, not a big deal," but it is, at least for me.
Yeah, I'm sorry about that.
Yeah.
Um,
So that's kind of where I'm at, and I'm going to see a medical oncologist next week in New York City at Sloan Kettering, and we'll see where it goes.
whom are you
Um,
going to?
who are you? Excuse me for interrupting, Ben, but I do have a little bit of background on this one.
Yep.
Um, it's good to meet you, Ray. And we are, and I'm sure you are really grateful to Stuart for navigating you a little bit.
Yep.
The last we spoke, I heard you were going to see one of the two. First of all, we think it's exactly the right thing to do to to get into the care of a GU medical oncologist right now, even though you might need some initial treatment. It should be guided by the GU medical oncologist. The last we heard, you were looking at Westchester
Correct.
MSK.
I had an appointment
Oh,
with Keegan at Westchester, and who I've heard good things about because I've got other friends that saw her. And I talked to Stuart, but Keegan was still another week or so out. She was end of next week, maybe the 21st or something. So I called MSK and I said, listen, if there's another opening in Manhattan, I'll take that. And they contact me today and they're like, yes, there's one on Monday morning. So I'm going down Monday morning.
So, what is much more important than time is the doctor. I mean, I appreciate that you're anxious. Who have they assigned you to?
Um,
Because let us just say we there are
ahead.
certain doctors that we have experience with that we might not recommend. There are other doctors that we recommend strongly, and it isn't a question of just getting in to see a doctor. It's getting in to see the right doctor. Um, our experience with the Westchester GU MedOncs has been average at best. There are some great docs on York Avenue that we could make sure you get into. Um, we can also help you to get over um, to the Yale Smiler to the Yale Center in Greenwich with Dr. O, who's one of the best doctors in the country.
Mm-hmm.
But as I recommended to you, you know, if you can get in to see Dr. Rathkopf, who is Ben's doctor, or if you can get in to see Dr. Ryan, who we know, these are the best in the country. You don't, our experience has been that you want to know the doctor you're going to, not just get to a doctor.
That's kind of hard to do when first time you've done this. So
Well, that's why we're here. That's
yeah.
yeah.
exactly why we're here, because we can facilitate getting you in to see some of these doctors. And that's why we gave you the names, 10 days ago. We really would like to see you get to the best possible doc.
Right.
I don't know. Do any other of the moderators want to comment on this? Len, I know you've had some experience using people in Westchester. You're a former Connecticut. What do you call it? Connecticution? I don't know. What's something?
Connecticut, I think,
Connecticut?
right?
Yeah.
Right, Dr. John?
Oh, Dr. John's a Connecticut, and we've got a few
Yeah,
Connecticutans
yeah.
here who are really well experienced. So go ahead.
Yeah, so I mean, Yale New Haven's got several good GU medical oncologists, and Dr. O is part of the Yale Smilo Cancer Group. He's in Greenwich, if that's closer to you. And you know, the docs Rick mentioned in New York of MSK, they're all good. So you know, it's just a question of convenience, I suppose. You know, in getting to any one of those locations, they're all very good doctors.
Well, I'm pointing to see Susan Sloven, I think.
Aha. So Susan Sloven is an excellent doctor.
I went to the
but it's, and we've had people who really like her. I'm thinking of a fellow who actually moved down to Dallas, who had a great relationship with her. By and large, her bedside manner is really difficult. She's not warm and fuzzy. Let's put it that way. She's smart. She's great. If it were me, she would not be my choice. But she's a very good doctor. If you could get to see, and that's why we usually don't recommend her, because she doesn't consistently get high marks with the patients, although it's not for her technique. That's why we'd say, look, if you could get in to see Dr. Rathkopf, or you could get in to see Ryan, or you could get in to see, you know, one of the others. Larry Fish sees Dr. Audio down there and likes her a lot. We like to refer people to doctors who we know you're going to be happy with. And you may be happy with Slovin, but I'd put it at a 50-50. So, and anybody else want to comment? Especially anybody who's going to MSKCC right now.
I mean, I just want to put in. I see, Bob, your hand is up. I just want to put in that the importance of the doctor. You have metastasis with a low PSA. That's unusual. That requires a doctor with skill who knows what they're doing. That's why it's so important that you get a good doctor. You have Gleason 7, which doesn't mean you're going to die tomorrow. You have flexibility to choose a doctor who will know how to treat your rather unusual presentation. You got to choose a good person in a situation. I mean, particularly in a situation like this. This is nature's way of telling you choose a good person, and don't be impatient. Bob, what would you like to say?
I'd like to say, first of all, I agree with everything that Len said, and I'm a recipient. Take my word, I hate to say it, I'm a bad example of what it was like to see two doctors at two different facilities that were unbelievably bad, horrific. And it was thanks to AnCan, Rick and Len and some others here that I was fortunate to find a good doctor. Patience is worth it. The better the doctor, the better the care, and I am so happy that I was happy to get to the doctor that they recommended. So please take their recommendation.
Thank you, Bob.
Thank you, Bob.
Your hand's up, Rick.
Oh, I didn't mean to put my hand up, but I will just say this: you won't go wrong with Susan Slovin. You won't. She's a sort of a doyen. She's been around a long time. She really knows her stuff, but you may not be happy with it. That's all I'm saying. That's all we're saying. So you know, you can't. It's not bad, but we might be able to make you happier if you went to see, say, I mean, Ben can talk about Dr. Rathkopf, Larry can talk about Dr. Audio if she's available. I can certainly tell you Dr. Ryan's schedule should not be too full because he recently moved there. I know him from UCSF. He then went to Minneapolis, University of Minnesota. He was then the chief executive officer of Prostate Cancer Foundation for a couple of years, and now he's at MSKCC, and he has a very good bedside manner. He's also smart. He's the guy he was the principal investigator on abiraterone many years ago. So we can only leave it with you, but we'd really encourage you not to rush in, because we'll get this cancer taken care of, whether it starts on Monday or it starts from 2 weeks on Monday. It's not going to that different. And I will also say to you, it's very, very hard to switch doctors at MSKCC. So once you get with one doctor, even if you're at Westchester, there are guys here who will tell you they've been in the satellite facilities like in New Jersey. They can't switch. They want to go see somebody. It's very, very hard. The only good news is if you don't like your doc, we could switch you over to Dr. O, because it's a completely different facility at Yale Greenwich, which is something to bear in mind.
Right.
Yeah, what Rick is saying is very important. I mean, we're tossing off these ideas and these names, but it really is a significant decision to make. And he's completely right that once if you're able to get in to see Dr. Radcliffe or Dr. Ryan, they are world famous. I mean, country famous and great doctors, top of the line. If you can't see them, I would certainly say that Dr. Audio is a great third choice. I love her as a doctor, and she came highly recommended, and I've been very happy. With my difficult case, most of us have difficult cases, and I know that I'm not speaking that he was pretty happy with Dr. O. So if you see one of those top doctors at Sloan, I think that's a great choice. And then if you have to switch, and you have to switch to Dr. O, because even if you end up with Slavin and you don't like it, there are plenty of roads that you can follow. And it's a key point that you get a lot of time, even if you have a aggressive disease, because your father or something unusual. These doctors can all recognize unusual types and strange patterns. And you don't want to be with somebody who is not so experienced, and then you're going to be kind of stuck with them in that situation. Okay, that's my 2 cents.
The message should be clear, Raymond. So, do you have more for us? Any more questions?
Well, how would I go if I went to Dr. Ryan or something? I mean, I can easily tolerate bad bedside manners. If it's a good doctor, I got no problem with that. But I don't know what's involved with seeing Dr. Ryan. Is going to be another, do I got to call him back again and ask for Dr. Ryan? Is that all it takes? I don't know.
Well, I mean, I would say that
I tend not to be my one of my problems is I tend not to be, what do you call it, too aggressive or forthcoming or something. I just, like a doctor, I'm like, if it's a decent doctor, I'll just kind of go with the flow. But in this case, I can't just always go with the flow.
So lesson number one from at AnCan is be your own best advocate. That's
Correct.
I don't have a T-shirt on. Maybe somebody else does, but they can lift it up and they can show you. So we know it's sometimes hard for people to speak up for themselves in front of their doctors. We get it. What we hope we can do is train people and navigate them and teach them how to do it, because we feel that it pays off in spades. And we get that there's a resistance or reluctance. I think if it were me, I would probably call them up tomorrow and say, look, I've been doing my homework, and if it's possible, how long would I have to wait to get an appointment with Dr. Ryan? How long would I have to wait to get an appointment with Dr. Rathkopf or Dr. Audio? Now, at the same time, if you're doing that and you give us a heads up, we can work back channels. Ben can send a note to Dr. Rathkopf and say, look, there's a new guy could you see him? I could send a note to Dr. Ryan. There's a new guy. Could you see him? We can help you, but we can only help you with sort of guidance from you. So if you take the lead, we can support you. And we feel that we can make a difference. I mean, like with Bob wasn't Bob was dissatisfied with both of it, with his docs at Moffitt and elsewhere, and we helped him, and he's now very happy with his doc. Herb Courtney, I see Herb Courtney there. He had a whole problem with his doc. We got him over to somebody at UCLA. He's thrilled with his doc now. I think that what you'll find, Dr. Jack, boy, was he was a problem. Well, Dr. Jack was a problem. Boy, we had to pry him out of MSKCC. We had to get a crane and pull him out. But now he's with a doctor in South Miami that he loves. So, right, Dr. Jack? Do I lie? Do I lie, Dr. Jack? Go
Mark
on.
Valance, are you still? Mark Valance has a message for you, Ray, if he's still around.
Ah, there it is. Yep. Very
That's right.
good.
It's about, think of how you're going to feel if you don't stand up for yourself and the wrong decision gets made.
Right.
Okay, we do have to move on. There was one, John, I'm sorry. Yeah, John, the last
Yeah,
hand up.
just two very quick comments. One is I would like to congratulate Decipher, which in the almost complete absence of clinical pathological danger
Mm,
signals, called this
mm,
metastasis. I think
mm,
that's pretty good.
mm.
The other thing is I'll just mention that I have a doctor with crap bedside manner, but excellent clinical judgment and knowledge. And I've gotten the best of care since I got switched to him.
Thanks, John.
Thank you.
So you give us some, if you need some help, holler. We're happy to help you, Ray. You let us know what you want to do, and if you need a note from one of our guys to send to their doc, or for me to reach out to who I might know, we're really happy to be of assistance.
Okay.
But and I will say we're happy that you are considering doctors on York Avenue rather than in Westchester, and Dr. O too. That's Len's doctor, and other of us know Dr. O. So if Greenwich is convenient for you, we can probably, with a bit of luck, get you in pretty quickly given your situation. I mean, all of these docs are caring. They're all compassionate, and they all will respond quickly when we say we've got a de novo metastatic man who wants to see you.
Okay. Thank you.
So Keith, unfortunately, this turned out to be a tough night for new people. Is your issue something that could wait till next week? Are you at a critical juncture in your treatment that we should talk to you tonight before you make a decision?
Nope, I am just in the early stages of figuring out what my course of action is um, with my situation. So yeah, I can wait for sure.
We look forward to seeing you next week. I'm sorry we weren't able to get to you tonight.
No problem. Sounds like a great uh, cast of characters with lots of knowledge.
Yeah. And Keith, if we happen to get through quickly tonight, we've got this room until about 20 after the hour. So if we get through tonight, I for one am happy to work with you tonight until that time. But the multiple sclerosis people kick us out around 20 after the hour, wherever you are, wherever you
I'll
are.
I'll hang in.
Hang in, okay.
Keith, could I have a last initial just because we've got three Keiths?
Oh, it's Keith R.
Thank you.
Rarely heard from Jim Marshall. What would you like to share tonight?
The thing I could do happens to be to postpone it a week. Okay,
Oh,
if there are others here.
Go ahead, Captain. You
Okay,
always give to others, so let us give to you, please.
okay. I don't talk much here. Brief history: diagnosed June of 2017, stage 4. Started Lupron plus the abiraterone in August. I did that for 5 years. A treatment holiday started in 2022. I've been on a treatment holiday 33 months now. Okay. The PSA is started to creep up from March of 2024 at 0.03, and now it's up to 0.07. So I engineered a referral from the VA over to Dr. Channing Paller, and I saw her today.
Oh,
And so she suggested a few courses of action down the road at the time that the PSA starts to increment. Now, the bad news is testosterone has gone from 22 in about March. Last month it was 320, and this month it is 511. And surprisingly, and with the PSA dropped from 0.09 down to 0.07. So she looked at my situation. All of the metastases were in lymph nodes, which she says, which is a better situation than within bone mets. And so what we are going to do is just to watch it for now. And the trigger point to decide something is 0.1. And at that point in time, now also as a sidebar, in March of 2024, I had a triple bypass coming out of that with AFib and peripheral neuropathy and blood clots and hypertension, which I've had since essentially 84, essentially anyway. So in the choice of drugs, and also EKGs, I bomb those because of a thing called QTC elongation time, which Lupron is known to affect. So with her suggestion, either essentially abiraterone mono, or I could do Orgovix abiraterone, or she happened to mention there is a trial going on, and I didn't quite catch it all. It's something that will increase the amount of time abiraterone will be effective.
mm.
She briefly mentioned that. And so, depending upon how the PSA goes next month with this jump of testosterone up to 511, then I may be there sooner or maybe not. She said, enjoy it while you can. And I said, thank you very much. And she is a great gal, but she's type A, and you have to sit there and concentrate because she's a mile a minute.
Are you happy that you've been referring people to her, Captain Jim?
Absolutely. And I told her that. Another thing is, just as a sidebar, any of the veterans, I hooked up with her nurse coordinator, and she will be referring veterans over to the veteran support group, she said. So that's always good. So we'll
Excellent.
see what happens.
Thank you, Jim.
Jim, did she give you a cutoff as to when she might want to do a PSMA? Did she give you an idea?
She just said periodic scans, namely CT plus a bone scan, but I think it was going to be somewhere about one, she said, that she would do essentially a PSMA scan. But there would be scans prior to that, which would be the CT scans and the bone scans.
I think I think if it was any of us here, we'd want to see a PSMA a little earlier than that.
I probably would. Now, the thing which is my big concern is the heart issues, impact on the heart,
Yep, yep,
because
yep,
I
yep.
do have a heart murmur, which all of the docs listen to me and go, "You got a murmur." And although she said, "Well, you do have it, but it's not that bad yet." So at some point that may
Yeah, stick with me, kid.
some work
Yeah.
somehow. So
And don't be creeping into the active surveillance group, Captain Jim, because that's for pre-treatment. All right, just saying, man.
right, sure. Okay, that's it.
Thank you, Jim.
Good luck with that.
Luke, it is your turn.
Dan has his hand up.
Oh, I'm sorry, Dan.
Yeah, Jim, you mentioned Abby that might put you on. Would that be the other connected medication with Abby?
Well,
Prednisone?
actually, she didn't mention that, but she did within the trial. Within the trial, they use abiraterone and the dexamethasone, and there's another drug which somehow will go into the gut and take care of the testosterone in the gut. And I have no idea what that is. But no, she didn't. She did not mention the prednisone, and I forgot to ask.
All right. Well, don't be signing any clinical trial papers before you talk to us, okay?
Okay, so
Oh, am I up?
yes, sir.
Oh,
Your turn.
hi everyone. I just wanted to ask the group, have you ever experienced like persistent knee pain, like after being on ADT? Like right now, I can't really, even when I'm sitting down, I feel the pain in my knee and can't really like exercise much, like bike or hike or, not much less like ski or snowboard. So I was wondering if you think this is some form of sarcoma, or should I see a doctor, or it's just regular like psoriatic arthritis that that just happened to rise up. Because I saw this YouTube video of this guy recommending to walk backwards on a treadmill. So I was walking backwards, and it helped with my left knee pain. But now I got like really persistent pain in my right knees, and it's been for a few weeks, and it's not going away. So I'm just curious if you, gents, have experienced the same kind of symptoms with your knee after going on hormone therapy.
Jeff Markey, your hand is up.
Yeah, well, I've had both knees and a hip done since I've been on these drugs. I've got osteoarthritis. I've also got a problem with the thumb and the shoulder, and it's nobody else in the family had it, so it's I think it's one of the things you can get, but you might be cortisone shots help a lot. Not as much for me, not as much in the knee as it did in the shoulder or the back, but it's or my fingers. But it's cortisone shot may work for you to stop that from hurting. You usually have to see an orthopedic guy about that.
Okay, I just making sure I'm not being paranoid and it's really related to my cancer, if it's any precursor to like bone mets. Yeah, even though I had a PET scan like a few months ago and it was just isolated to the seminal vesicle at this point.
What are you taking the drugs like Lupron or Orgovyx?
Yeah, I'm on like 3-month Lupron shot.
That's all? Just 3 months? That's all you've been on?
3-month intervals, yeah.
How long have you been on it?
So, it's been 9 months now. Oh, actually, no, it's been just over 7 months, actually.
Yeah, that's a little earlier for osteoarthritis, I would think. But
oh yeah.
A cortisone shot in the knee may totally resolve it. But just speak to a doctor about it if it continues.
So you wouldn't suggest I bring it up to my radio oncologist, right, or just
no, it's orthopedic. You need an orthopedic doctor. They're the ones that do, and you got to have one that specializes in the knee and the hip. Some of them do, hands. Some of them do necks. So they all do different parts. Many do different parts. So it's you want one that's a knee hip specialist. And where do you get medical care?
I'm with Kaiser, Southern California.
Well, just ask your PCP to give you. You could also have X-rays done. They're really free about that. They've been with me at least. So you could ask to have X-rays done. That could narrow it down. Your PCP could do that for you.
Okay. Yeah. No, I just thought maybe I was reading too much into this pain, thinking it's somehow related to prostate cancer cells spreading or into the bone. But
I think you might be. I think you might be reading too much into it. With a non-detectable PSA, and a bone metastasis and a sarcoma are way, way down the list of possibilities compared to an orthopedic problem. I agree with Jeff. I think a visit to an orthopedic doctor might be good.
Okay. Thanks, Dr. Jeff. Thanks, Jeff.
What say you, Wes?
I've had stuff like this a lot. If you go backwards, you'll screw up all sorts of things. It's a good idea, but I've done the same thing. I'd go get x-rays to prove that you don't have something bad. They'll do that prophylactically. You really need an MRI, but they won't do that. And then go to a physical therapist and tell them your story. That's where you need to end up anyhow, is how to mitigate your pain and your movement, no matter what the cause is. But a good physical therapist will help you out. I've had similar issues with my knees, basketball, walking backwards. The other thing that you might note is that things cross your body. I used to carry a purse on my left side, and my right elbow was sore swimming. And the chiro that was working on my dog goes, "Oh, it often goes diagonally." And they see this in quadrupeds, not so much bipeds. So anyhow, like the guys say, take the simple answer first.
Yeah, makes sense. Sounds good.
I agree.
What do you think?
Did you call?
Yeah, your hand was up.
Sorry, yes, it was. The one thing I would also suggest you do. I can understand how walking backwards screws you up badly because you're using all kinds of muscles that you never used before. So, before you do some of these things that you see on the internet, discuss them with your doctor. Be careful of Dr. Google. Now, that said, the one thing that I did want to ask you is, have you had a DEXA scan? Did they do a DEXA scan for you to
Yeah,
check
I
your
had a
bone
DEXA
density?
scan, I think a few months ago, and it came out normal. So
Okay. So as long as you've had a DEXA scan, I just wanted to be sure that you don't have any osteoporosis, because that was my situation. I had no idea, but I was osteoporotic. And just as long as that you've cleared that up, I will hand back to Professor Ben.
Yeah, don't
thank
sweat
you,
it.
everyone.
Sleep easy. Doug from Portland, you are next.
I have an update. I have followed your advice. I have got myself into the VA system. I went to a PCP who I liked very much, and I thought she would refer me to a urologist who would refer me to Julie Graff, whom you recommended. And she said, "Well, I don't know about all that. I'll just refer you straight to Julie Graff." So I had my appointment last week, and I was very satisfied with what she had to say. That is that I started out with a Gleason 9 and had radiation and ADT. And while on ADT, I had essentially undetectable or very, very low PSA. And when I went off it, it climbed quite rapidly up to about 0.75 and has remained there for 10 months. So we are satisfied that it has stabilized, and we're going to watch it for significant changes, but I'm happy with it. This is something I have had difficulty getting information about to know what to expect as far as, like, is this a bump or recurrence or whatever? And I am fairly reassured now that I'm on a relatively normal path, if there is such a thing in this disease. Actually, I did find a graph that is fairly representative of what we should expect with the situation I've had. I think I'm on that little green line that has an arrow to it, the middle line coming up from the bottom of the graph. So I'm on the appears to be I'm on the horizontal line that's heading off to the right.
Good.
It's good.
That's a graph that's similar to what Rick described a couple of weeks ago that he had shown to him by someone in a seminar. That's all I have.
Good.
You, Doug. Oh, I'm sorry. No, there are people who'd like to comment. Jim Marshall.
Congratulations, Doug, and where the VA system works if you play it.
It has been doing so. I hope it continues to do so.
Dr. John?
And I had at one time had a very interesting conversation about cardiac risk factors, and I think, Doug, you got turned down to see a cardiologist or something. How did that all work out?
I was referred to a cardiologist, and this is at Kaiser, and he said, you shouldn't have had the test, and I'm not going to see you, and just get on statin, essentially. That's the message I got.
So did they talk you into starting a statin then? Did you get on one?
I am on rosuvastatin now.
And what was, I don't want to take up too much time, Ben's got a lot to go, but what was the rationale for being on a statin if you disregarded the coronary calcium score? Because your other markers are very benign.
Actually, all my blood tests were quite good before. They're really good now. I mean, I'm down to an LDL of 30.34. I mean, 34. Yeah. Okay. So it's quite useful in that way. the reason I was able to talk my PCP into having me get that test was that I told her I had heard enough about statins that I didn't want to be on one up until that time. And after I saw the calcium score, I said, well, I will consider it. I'm sorry. I told her before I had the calcium score, if my calcium score indicates that I should, then I'm going to be very receptive to it. So she authorized the test, although the cardiologist said he wouldn't have authorized the test for me.
Huh, I see. Okay. Thanks.
Thanks. Rick, your hand is up.
Yeah, I just want to congratulate your persistence, Doug, and I'm really pleased that you finally got to see Dr. Graff. And I also feel that now she's part of your medical team, that somebody's going to keep a close eye on this, and that, even though you're at 0.5, she's there, she's watching it, she knows what to watch for, which is very different to what goes on at Kaiser. So I'm pleased. I'm also curious, I ask most people how you felt about your interaction with her. Did you, were you happy? Were you not happy? Was she, would you recommend her, et cetera, et cetera?
Simply amazing. Very, I'm very, very comfortable talking to her, very comfortable with what she has to say. I would certainly recommend her.
Fantastic.
Yes. Fantastic. Thank you very much.
And I'm curious, did she tell you, is she working just only in the VA right now, or did she mention that, or do we know where she's working? Because she's been elusive.
I believe that's true, although if you go to the Kaiser website, it shows her as actually not a GU oncologist. I forget what, but she's listed in the Kaiser system. I think she's listed in the OHSU system. But I think she is a veteran doctor.
Okay.
And I was also pleased. I didn't really know what my appointment with her would be considered, whether it would be considered to be a second opinion or what, but she was very, I'm not going to say insistent, but she was very clear that she wanted me to stay on her, she wanted to stay on my team. And she's going to be contacting me in 6 months, and we're going to follow up. Yeah, she's
fantastic. Great. And God forbid you have any issues between now and then. That's
right.
Sure you can reach out to her.
That's right. We're watching PSA, and as I'm very confident that I could reach out to her at any time.
Fantastic. Really pleased you got there in the end.
Me too. Thank you very much. I would not have done that without your assistance and guidance.
Thanks, Doug.
Is Dr. Graff back at OHSU? Because I don't see her there.
My understanding is that she is at the VA, which is all on the same campus. Well, it isn't really the same campus. It's just on the same side hill. No, my understanding. I met her in a VA facility. It is at the. It wasn't at the OHSU hospital. She was at the VA hospital.
Okay. Yeah, I don't think she's back because I don't see her on the list, and they've told me if I want somebody at Sokolova.
Are you a veteran? Okay.
Okay, we should move on. Dan, spotlight is on you.
Oh, thanks. With the side effects, I'm currently off abiraterone and prednisone, and just on last week I got another injection of Lupron. And got a second CTX scan. I was talking about this last week. It was 649, which is quite high. She recommended I do it in the morning, and came out 743, which is really high. So right after my Lupron shot, they gave me a reclass shot of zoledronic acid, but I still continue to have a really bad hip pain. It's really hard to walk. And so yesterday my primary recommended I get an MRI, which I did today. I'm anxious to see what the results of that are. But in the back of my mind, like all of us, I wonder if that's cancer or just a pulled muscle or whatever. I was wondering if anyone else had these kind of issues with the strain in the groin area.
What were those numbers that you put out that you were measuring? I missed that, Dan.
Yeah, that was the CTX scan, the cross. It was 6:49 last week in the afternoon, and she indicated, the endocrinologist indicated I should do it in the morning, so I did that Monday. It was
Okay.
7:43.
Can one of the docs tell me what that scan is, CTX, and what those numbers mean?
Dr. John knows, and the average for a male is about 300, 350 at our age.
Dr. John, what is that CTX scan that we're talking about here?
It's an indication of bone turnover.
Okay.
The more bone resorption that's going on, the higher the C-telepeptide score will be. So if it was high, that means basically that he was losing bone.
And what's it called again? C-telepeptide, did you say?
I'll put it in the chat because
Yeah,
it's a
please,
big
thank
word.
you.
And
That's a long word.
Thank you. I mean, I had 3 zoledronic infusions over 2 years. When I was diagnosed, my diagnosis was a bit similar to yours, Dan, and that was because I was osteoporotic. What's your DEXA scan showing?
I can't remember what it was, but the bone scan and the other scan, density scan, came back that there's osteoporosis in the spine and osteopenia in the hip and in the neck.
Okay. So I also had the osteoporosis in the spine, and I was quite a bit younger than you at the time. I did change the way that some of my exercising, and over a period of 2 years, I really improved my bone density. I mean, it's gone back. It's gone back quite a bit since then, but that's just age. But there's a lot that you can do, and especially at Kaiser, ask them to be referring you to a physiotherapist who can help you find some suitable exercises to stress your back, which is what you need. What I did. I started doing some squats with weights on my shoulders, and I used a Smith machine as well, so it was pretty safe. But that's the sort of thing I think makes a lot of sense. In a way, but it's water under the bridge. It would have been probably good with if they knew you were osteoporotic, then, and I didn't realize that, then they should have been giving you something to boost you from the time you started doing your not weight. I mean, which is, I was lucky enough that I had a great doc who was smart enough to know that I needed a DEXA scan as soon as I went on Lupron, but yeah, that's important.
Was it ever a fear in your mind that cancer had gone into your bones?
Not really. I mean, I guess I think I'm lucky because I never really had a lot of anxiety about I had a stage 3 diagnosis. I didn't have a lot of anxiety about it. Did it occur to me? Yeah, I think it occurred to me, but when I found out that my bones were soft, even though I exercised like crazy, and I figured that's that's what it's about. So I think, and Dr. John and Dr. Jack can talk more to this, but I think that if we allow our monkey mind to run away with thoughts like bone mets, we've heard that tonight. It's just not healthy. They may be there, but I think it's so important that we all live in the moment. And when we find ourselves thinking about that, we pull ourselves back to the moment. I mean, from our therapists in the room, any good tips to what? I mean, Dr. Jack, you're a good one at thinking about things that might be there when they're not. How do you pull yourself back to stop that?
Become more philosophic about it. When you hear hoofbeats, it's usually a horse, not a zebra.
That's the expression they teach in the first year of medical school, that it's probably not a zebra. But there is a tendency.
I can remember 1961. That was my first year of medical school.
Yeah. But there is a tendency, this is the fear that every physician has when the patient comes in with a stack of papers because they've been getting information from Dr. Google. Dr. Google will convince you that you have a disease that's only ever been recorded twice in human history. And yet, those two people really had the disease. So it's a slippery slope. It's a slippery slope. But I think the lesson here is let's focus on what's common. And, I know that my plate is pretty full, just having what I already have. And I don't have much bandwidth to have a fuller plate by speculating that I have this, that, and the other. Right. So, and I'm putting on my patient hat when I say that. I'm pretty stressed by just dealing with what I'm dealing with.
Right.
But there is this tendency to now that we all have the internet, to go, oh, let me look for something else. And but the other piece of that equation, I think Jack would agree, is trust your doctor to tell you, you might have a rare case of zebra disease. Let the doctors find out if you've got something exotic. Anyway, that's my little soapbox.
Yeah.
Thanks.
I like Dr. John. Why don't you, for the record, in case people don't read the chat, why don't you give your advice too? I like it a lot.
Well, it's scientific proof. Almost everything that we worry about never happens, right? Our kids falling in a ditch and things like that. So it's proof that worrying works.
Oh boy.
So with that, let's move on.
I do want to say, did you get the Zometa? Have you had it yet or not?
Zometa?
Yes.
No, I got Reclass, zoledronic acid.
Oh, okay. So they gave you Reclass. Okay. So Reclass is the same as Zometa, except it's a smaller dose. But you just have to be a little bit careful. Len has some experience, and there are some things Len, do we need to worry if it's given in a lesser dose like Reclass than Zometa?
I can't answer that, Rick. And I had a reaction from an infusion of Zometa, but it's, I think, not common, which is fever, violent shaking, chills afterward. But I don't know if there's the lower dose is without that possible symptom.
Yeah, I was fine with it. I got 3 doses, but there isn't it Claritin that you suggested you take beforehand?
I did not suggest that, and it was not suggested to me.
Oh,
I don't know if it helps.
Wasn't there something you did suggest though?
Not that I can recall, Rick.
Okay.
I think the denosumab is a little more effective than zoledronic acid, isn't it?
Yeah, but it's more expensive, and Dan's at Kaiser.
Yeah.
Uh-huh.
Thanks, guys. Move on, Ben. Move on, quick.
I was at Kaiser too, Dan. So
I hear you. I hear you. Thanks. Thanks, Rick. To you, Ben.
Thank you, Dan. So Jimmy G, back from the hospital.
Well, everyone,
I must
glad
ask
to
you
be here.
to
What's
make
that?
it short. We're tight tonight, so
Oh, I'll make it short, all right. Just like my penis is shorter, everything that came
yeah,
after it
yeah,
is a
yeah.
little bit longer.
Knew what you meant.
But you know what I mean. I was in a hospital for about 4 hours today. I could not. I wasn't getting any urine out of the catheter, despite how much I drank, despite how much I tried. I didn't go crazy because I've done that before. This is like the third time I've had serious urgency and not been able to do a thing about it since I got the AUS and started in 21. It is it's wearing on me, no question. I'm looking for answers. I have some faith in my doctors, and sometimes I don't. But basically, the space of it here is that the charge nurse who did come in with one of those big saline syringes and injected saline and withdrew an equal amount of urine until it was reasonably empty, got about 400 cc's, which is not a tremendous amount. But for what I've been through, it might be a lot. It might not be a lot. I had 800 when I had the AUS installed, and there was nobody to catheterize me that day. So maybe I'm kind of broken down. I'm not as good as I used to be on that point. But who wants to be good at that? Anyway, she said, talk to your urologist. There's every possibility that he will allow you to have this at home to do yourself if you should have another episode like this. Because I had to go to the emergency room. The doctor told me to go to the urgent care center, and they didn't know what I was talking about. When I got to the hospital, they're like, oh, those guys don't know what they're talking about. A lot of the time, they certainly don't know what this is. And then, sent me on my way, but it took a long time to get to me. I think of myself as resilient, but I was doing that thing where I was like standing, pawing against the wall because I couldn't help myself. It was so painful. So now I'm sitting here. I'm back to, back home. It's a beautiful 70-degree day here in Washington, but I am freezing to death. But not to death. I've just been through something again. So I just thought it'd be great if I come in here, pain shared is pain lessened. I learned that a long time ago. And then for now, that's all I have.
Thank you, Jimmy.
Jimmy, are you still catheterized or not?
Oh yes, yeah, still catheterized. They called what do they call it? When they put the saline, they call it. Oh, come on. They call it releasing it or something. Not that, but something like that. Because I couldn't get anything out of it myself. So that's why they inject this with the big syringe. They inject saline and then draw out the saline with an equal amount or so of urine and do that until you're empty and reasonably empty. And that's called something I can't remember, but you can see what it's called. You can look it up. And they were good to me once they got to me. But the first hospital I went to, it was absolutely jam packed. There was no way I was going to be able to get in, no matter how much I belly ached. So I went to a different hospital. I left Sibley and went to Suburban. Suburban was a better choice, but it still took a while. As you know, emergency rooms these days are often dominated by people who don't have surgery. They don't have physicians. They don't have insurance. They don't have a doctor. This is common. So you have to expect when you go to an emergency room.
Jimmy, how's the inflammation? Is it going down? Do you feel it's going down?
The inflammation, it might be down, but the swelling from the hydrocele surgery is still there. It's less than it was. But he wants me to feel around in there for the AUS. And I tell you, I was trying to feel around for it today, and I couldn't feel it yet. And it's hard. I've got one testicle. I've got another testicle. I've got what's remaining of the scar tissue of the hydrocele, and then the AUS has migrated to behind there somewhere. I feel like asking for an x-ray so he'll actually know where it is instead of telling me to try to find it. I'll see him again tomorrow or the next day. I'll let you know next week. If I start talking, I won't stop. I'm a little upset, but I'm okay.
Gary Peters?
I thought I had a question for Jimmy, but he addressed it.
Damn it, Peters. I wanted to hear from you. You hardly say a thing. And now my opportunity is gone. Next time you think of something, write it down. Thank you all.
Herb, it's your turn.
Well, just a quick update. About a month ago, I managed to get COVID again, but thanks to having all the latest and greatest shots, it was just like a mild cold, so that didn't have any effect. Just had my recent quarterly checkup with Dr. Rettig and the blood test and a video conference with him, and everything's pretty much status quo. My testosterone's hanging in there on the low end of the normal range, about 339, and my PSA's crept just a hair. It's still down to 0.06. So, I spend about 3 minutes on the video with Reddick, and he says, "Yeah, everything looks good. See you in 3 months." So it's all good. Darolutamide's hanging in there for me well.
So we should add, for those of you who don't know, that Herb's on monotherapy darolutamide, which is why he has a testosterone level, and yet he's controlling his PSA with the darolutamide.
Yep.
Let me ask you a question. What is your estrogen level, and are you having any nipple tenderness or gynecomastia with the darolutamide alone?
How is my what level?
Estrogen.
I don't know. We haven't looked at that in quite a while. I looked at it a long time ago after I started getting my man boobs, but I got them, and some treatment didn't work to try and get those down, and so I just live with it. So I haven't been concerned much with the estrogen.
You did have radiation treatment?
Oh, I had a radical prostatectomy.
No, radiation on your boobs.
No, didn't do that.
You didn't do that.
Yeah, I mean it's not that much of an issue. So,
all right.
I'm 87. I'm not worried about them.
I don't think they're. Yeah, the way I've seen it before, I think we're quite a ways.
Gary V.
Stevie isn't even talking to us. There you go.
A question about the darolutamide. I'm about to start it, but why did your doctor not prescribe Orgovix or something else along with darolutamide?
Well, I had been on my PSA had been high actually on purpose to get a bunch of scans and stuff, which my cancer doesn't involve PSMA. So, so we got it back down pretty fast with Rick. What am I trying to say? The ADT, the most common.
Lupron.
Lupron, yeah, with Lupron and darolutamide, and then once it got down to 0.02, we just stopped the Lupron, and the darolutamide alone has been keeping it down. That was like a year and a half ago. So, if my PSA is down that low just with darolutamide, there's no point in going through the side effects of the Lupron. So I'm pretty happy.
Well, that's actually really good news.
I'd add, Gary, that was Dr. Reddig's choice. He suggested to Herb that he go on monotherapy. Now, we've had a bunch of people in this group who have been on monotherapy, darolutamide, with good results, and it's a therapy that our men live well with, and so we always suggest it be raised. But in Herb's case, he didn't have to raise it. Dr. Reddig came up with it. That's why we
Yeah.
like that's one of the reasons we like Dr. Reddick.
And I should also say that I had a hematology oncologist prior to Rick suggesting that I switch, and she and I weren't seeing eye to eye anyway because she wanted to do nothing and just let my PSA seemingly go wild because she said, well, you're just treating a number. Well, for me, the number is all we got to treat because PSMA scans, four or five of them, have shown that my cancer doesn't express PSMA. So we got to treat the number. So anyway, that was the best suggestion I ever got. And again, I thank you, Rick, for getting me in with Reddick.
Herb, have you had an FDG scan follow up over the past year and a half?
I've had the prostate specific MRI. I've had the CT. I've had the what's the scan that begins with an A?
Axiom?
Yeah, Axiom. I've had them all.
Within the
All
past,
negative. All negative.
since you've been on darolutamide alone, you've had a Axiom scan?
Since I've been on darolutamide alone, no, I haven't had a scan since I've been on darolutamide alone.
Nobody suggested that would be worthwhile.
No, not really. Not as long as my PSA's down at 0.02 to 0.06.
Yeah, is that the general thought about that? That's you don't need to get an FDG follow up or an Axiom follow up, even though you have a low PSA.
Reddick's never suggested it. Of course, I don't know. It may be because of my age too. I don't know. I'm 87, but I'm very active. I mean, I still work out in the gym 3 times a week and do some volunteer work that encompasses lifting and walking and a lot of more exercise. So seems like all's good.
Okay.
It's great to hear.
Thank you for the information on darolutamide.
Yep. Great stuff.
We think so.
I had to fight my doctor to get it.
Wow. Well, and the best part is through my wife's insurance, she was a teacher. I pay $0 for it.
Yeah, my insurance actually had it. Darolutamide was less expensive than the Orgovix. My copay on the Orgovix was over $1,000. My copay on the darolutamide was right around $800, and I was able to get a grant through Compass Oncology to pay for it all. But this is the first time I've been following the studies on darolutamide, but this is the first time I've really heard such great news, other than what I've heard from Jeff Marche. So I'm hyped.
The side effects, my side effects from the darolutamide are just about zip. I mean, I don't really notice anything.
Fantastic. Thank you so much.
Okay, Joe Comanda.
I'm happy that I'm coming now because everybody's been singing the praises of darolutamide. I am taking Orgovix and been doing that since October, and things have been going pretty well. Testosterone and PSA have pretty much disappeared. And my doctor was not in a hurry to put me on doublet therapy. So it surprised me when she said this time, I think we ought to consider that. And the reason she's in the middle on this is that she takes into account the fact that a lot of the testing was done at a point when they were using PET scans as opposed to PSMA scans. And so she tries to figure out whether I'm serious enough, if I have a serious enough case of it to justify using the doublet, which was intended initially for people with more serious cancer, I guess. I may not be putting it in the best words, but that's the gist of it. but she is considering it, and she was considering Zytiga. She told me that I could also consider Orlida. Is it Orlida? Yeah, or Xtandi. I would like to do Zytiga, darolutamide, and she she thinks I'll
Zytiga
have
is
trouble with
abiraterone.
what's that?
Zytiga is abiraterone.
Right.
Nubeqa is darolutamide.
That's what I want, Nubeqa.
Okay.
Yeah, sorry, darolutamide. And I've asked about this before. I guess what I'm asking now, she thinks the reason is that I'll have trouble getting approval for it with insurance companies. And I think the only insurance company in the picture is Medicare. But it hasn't been FDA approved yet, as some of you at least would know. And I suppose it's a matter of time, but I don't know how much time. Any ideas about how I can, how I can suggest strategies to her or whatever?
Jeff, what are your thoughts?
Darolutamide's in the Medicare list. I know at Kaiser it's in our list. The thing is, what are you on now?
Just
Orgavix.
Orgavix.
Orgavix. So the recommendation is that people go on abiraterone first, because then they can go on Nubeqa, and you get a longer time. For me, that's been true. I got 2.5 years on Abby, and been about 1.5 years on Nubeqa now. So that's one reason they do it that way. Yeah, there are fewer side effects with Nubeqa, but you're on Lupron, so a lot of the side effects are still going to be there from Lupron that you would get with Zytiga. It just makes the hot flashes, well, it's a little bit more intense. It lowers your testosterone a little bit more. But, that's just the things to consider. The fact that there's been studies done about the fact that it's better to do Abby first. But, the thing is, these drugs only work for so long. And usually they do not want to have you switch over to Abby or lutamide until you've become castrate resistant. I mean, that used to be the way that we did it, or if you have metastasis. Have you had either one of those occur?
No.
Well, that's interesting. I'm going to let somebody else talk.
Gary V?
United Healthcare approved my darolutamide or Nubeqa without any problem. If your doctor writes it up correctly, it should go through with United Healthcare. I'm Medicare Advantage, United Healthcare, and they're assholes as far as getting approval, but they did approve it.
Rick?
Yeah, I just put a question to the organizers, but if my memory serves me right, darolutamide, first of all, Joe, I'm not sure that it's correct that it's not FDA approved.
It was approved by the FDA back in like 22, I think.
Oh, for this,
well, it was approved for non-metastatic castrate-resistant prostate cancer. It
correct.
was a very weird approval.
Yeah,
if I'm
right.
not mistaken, it was just approved within the last 3 months or so for non-metastatic hormone-sensitive prostate cancer.
So then it is approved.
Well, that's what I just said to you.
Yeah.
That
Okay.
I'm not. You said it's not FDA approved. I think it may be FDA approved.
Okay.
Now, the second thing is that you can talk to Dr. Haas about possibly doing what the other guys are doing here, which is the monotherapy, like Herb Courtney. So you come off the Orgovyx and you just go on and see how you do like that. You might feel better. It is a strategy that's used by a bunch of docs that we work with who are very reputable. It isn't something that first comes to mind with a lot of the GU med oncs, but with the ones who are more experienced, it's possible. So the the third thing I want to say is I still think the point that was made right at the beginning by Jeff Marchi, which is that sequencing wise, we think that you probably get more mileage out of doing abiraterone first before you switch to one of the Ide brothers. That doesn't mean to say people always do it. Some people will do, may want to do the daro first. There are other people. David Muslin's a great example. Went on the abiraterone, had really bad side effects, switched over to darolutamide, and was fine on it until he started doing a drug holiday. So abiraterone is ideally the way to start if you can tolerate it. But if you cannot, then darolutamide is a good option. We also tend to think, and Len and I have been talking about this recently based on some meetings I had with Johnson & Johnson, that apalutamide may be a better drug than enzalutamide. I have in my inbox, and I haven't read it yet, some theories as to why that might be, and I will circulate them to the Brains Trust when I open the email. At the same time, those studies were sponsored by the pharmaceutical company that makes apalutamide, so we have to be a little cautious, although the doctors who were involved in the trials are very reputable. So that probably confuses you totally, but I think that if it were me, I would try to start with Abby and see how I do, and prednisone.
So to clear up the record, the Nubeqa site does not talk about an approval for non-metastatic hormone sensitive, just the old ones.
Okay, so it's pending. What did it just get? Did it just get approved for metastatic hormone sensitive? Was that the one that
with only with use with docetaxel?
Oh, right. Okay.
Part of the triple therapy.
That's right.
They late last year they filed abbreviated NDA, which they call for the additional indication of hormone sensitive prostate cancer without docetaxel.
Okay. So, and was that metastatic or non-metastatic, or they didn't distinguish?
Oh boy, I think it was metastatic.
So then it gets down to perhaps. I mean, Gary V, what are you metastatic or non-metastatic hormone sensitive?
I'm metastatic.
Okay.
I don't right now. I'm not exactly sure whether or not I'm still hormone sensitive.
Okay.
Not.
So
but I'm metastatic.
Let me get back to Joe. It depends a lot on the skill of the doc. There are some docs who will go out on a limb and they will get it for you because they'll argue for the darolutamide because they'll say, you haven't responded well to the Orgovyx and this and that and the other. And they get it. And we've seen them do it. There are others who say, well, it's not FDA approved, so we're not going to even try for it. It really comes down to how much your doc is willing to fight for you. And Len Alfredo just updated something as well. I mean, there's a lot of action going with it, but we've seen guys get it who are in your situation, and we've seen other guys turn down.
Alfredo put something in the chat that seems to say it does have FDA approvals. Is that
Well,
something?
they've accepted the application. It's not
They've
approved
accepted the application. It's not fully approved yet, but this is the next step for
Oh,
approval.
they've accepted the application.
And
Okay.
it's the most recent thing I could find. So
Okay.
is it Bayer who makes Nubeqa? I think it's Bayer. So they're on
yes,
the
it's
road.
Bayer. No,
Yeah.
yes, it's Bayer that makes darolutamide. Yeah.
So all I'm saying is this was the most recent thing I found, and this is a step in the direction
Okay.
we're just. That's all.
How long does it take? I know you can't predict, but I mean, like, what is the typical time frame for it to get approval from this point?
Len, do you know?
Pre-Trump government.
Could be next month, or it could be 5 or 6 months. Nobody knows for sure.
Yeah, no, especially right now,
Right.
because there's so much confusion. Nobody knows what's going on. The FDA is the FDA still leaderless, or did that guy get appointed last week? I can't remember. And nobody knows who's on first.
Yeah,
So,
even if they have the leader, if the people who received this NDA were laid off, then there's nobody to push it forward.
Yeah.
No one knows.
Let me just interrupt a second. Nicole, I saw you just came on. You might, if you're coming on for the MS meeting, it starts in half an hour at 5:30. So please come back in 30 minutes.
Thank you.
Sorry, go ahead, whoever I interrupted.
Joe, are we good to move on? You have more?
Yeah, I think so. Go ahead. Thank you.
Okay, thanks, Joe. Wes, you got your earbuds back in. What's up?
Okay, well, I was getting information from somebody. Anyhow, thanks all. Thanks, Rick, for your advice. Everyone else. I'm over at UCSD. Lists, I think, is very good. I'm with a radiology guy, Siebert, who I think is outstanding also. So he's modified my care a bit. But my question, jumping to the end, is what kinds of hormone therapy are available? Siebert has suggested radiation and Lupron, and 6 months of that, and then see where I'm at, because my goal is not to waste my youthful years too much, and I'm willing to accept some downside risks with that. So I had heard that monotherapy wasn't recommended, but maybe I'm not in that category.
I'm sorry, I didn't catch what your status is. Were you in the
So,
illness?
so I have a 4-3 PSMA identified a couple of issues. Maybe it's in my seminal vesicles. Siebert's not convinced of that. He's taking a high resolution MRI. I'm having a gel implant next week with markers for radiation. And Rick, I am having a MRI of my neck along with a potential biopsy to exclude that potential false positive from the PSMA. The x-ray of the rib was non-indicative, so I said, let's fight as many battles up front as we can so we're not naive about what I should be doing, because it's a huge fork in the road. So I'm doing all that investigation. In theory, by April 1st, Siebert said he didn't believe that starting hormone first, in my case, was all that important. So he's going to start hormone therapy. I see the medical oncologist the end of this month, Randall, and I'll bounce all this stuff off him. But Siebert's radiologist, his take is do radiation either 10 days or 6 weeks, start Lupron, do that for 6 months, claim victory, see what happens, have a good year perhaps being off of ADT, and go from there.
So I'm not clear what the fork is. Sorry to be so dense.
The fork is I could be metastatic with cancer in my neck. So that will be determined here in the next week or so. Assuming that that's negative, and assuming that the seminal vesicles are not a big deal, I'm not going to have surgery. So I'm going to have radiation. So really the question is, what kind of therapy, hormone therapy, would be indicated? He just simply said Lupron. I have not been on anything. I haven't done anything. So it's the first game in town. And in some ways, I'm different than a lot of the people in the conference right here, in that I haven't been doing this for years.
I think there was maybe going to be a second look at the slides to see if that cribiform and introductal aspect was verified. That might have an influence of whether you go on one or two drugs. No, Len, he has had no therapy yet.
I have not had that second slide biopsy look, although I can ask for that.
Do people think it's important enough that it might influence future treatment? I kind of think so.
Yeah, and if you're going to ask for it, you need it. You don't need it from UCSD. You want it either from Dr. Zhao or Dr. Epstein.
Right. So we've talked about that, and I go, if I'm having radiation there, what does that tell me? It is aggressive. My Decipher score is whatever, 67, I think. So it is a high risk, not super high risk, but high. It's aggressive by some definition of aggressive. So what more do we need to know?
So let me just say that's not the definition. That Decipher score is high. It's high risk by Decipher score. That's not what defines high risk for prostate cancer. What defines high risk for prostate cancer is either the Gleason score, PSA, seminal vesicle invasion, extracapsular extension. Those are the factors. So, so we might not classify you as high risk, even though Decipher says so. Neither
well,
would,
excuse me, all of them seem to line up. So I had 4-3, and I had seminal vesicles based on the PSMA.
Okay, so that makes you high risk. So the
SVI
and you have cribriform. I'm not sure. I think if you have seminal vesicle invasion and it's been confirmed, then I would say I don't think it matters what they're going to tell you if you get your slides reread, because the SVI kind of trumps the other factors, and so we're going to treat you as a high risk candidate. So whether you're 4+3 with SVI or 5+4 with SVI isn't going to influence the treatment. What it may do is influence, God forbid, the cancer comes back, it may be influential then. So it may be helpful to know, but I don't think it's going to change what they do right now. What might change what they do right now is this PSMA scan you're going to get on your neck.
No, MRI.
Well, you don't need an MRI. You need a PSMA. That's what we said to you last time, because we want to know.
I already had. I had a PSMA. It highlighted the neck as a concern. When I raised that issue, they said they would have a high resolution MRI of the neck and look at that because it should be present in that as well.
So did it light up? Did it light up as a spot that expresses PSMA in the PSMA scan?
That's what one person thought. The radiologist was not convinced. And that's why he recommended doing this MRI. I don't do this stuff, so I'm just reporting.
I
Do you
get you.
remember what the SUV was for that spot in the neck, Wes?
I not off the top of my head. I could find it, but it'd take me a couple minutes of my files.
Did you say you were getting a biopsy in your neck?
That is going to be discussed after the MRI.
Oh,
And I have fairly good osteoarthritis, including shrinkage of some of the area in my neck. So there would arguably be inflammation there. That's what they had said before. I said, well, let's include that because if I have cancer up there, then I'm going to change my behavior pretty dramatically. So that should be done here in the next week or so, and I can report back to you what they find.
Mm-hmm. I mean, I think the key is to establish what's going on in your neck. I mean, if you've had a PSMA scan, which is a little indeterminate, it's not clear whether it's prostate cancer or if it is. And then they're saying, okay, they want to do this high resolution MRI. And depending on what that says, if it's in a position that they can biopsy it, I think we've got to run this down to make sure that you are, if it is prostate cancer or it isn't, because that could change things.
Right. I should have my, all right, findings neck, SUV. Let me see if I can find it. Okay, so abdomen, pelvis, prostate gland, no, thorax, technique. Well, in any case, speak to me a little bit about going just on Lupron or some other product. That's really my basic question.
Well, if it's not cancerous, then you would just the guidelines would suggest just a single first line drug, an LHRH drug. The LHRH drug of choice for us right now is Orgovix, but it's more expensive, as you've heard tonight. If you can get it and it's not going to cost you, that would be the way to go. Otherwise, you would go on an LHRH, either an agonist or an antagonist. If it were an agonist, you need to be sure, especially with this being unclear about your neck, you need to be sure you do bicalutamide for a couple of weeks first. So if they're going to give you a shot and they haven't given you bicalutamide and they're giving you an agonist, please be sure that they've given you a buffer first. If you're going to do an antagonist like Firmagon or the Orgovix, you don't need to worry about the buffer.
Okay, so the answer to your first question was the C3 facet joint was an SUV max of 6.14, and the rib, which also pointed out, was a 3.44. None of that means anything to me. But I'm trying to do the homework you suggest, which is, so far has been really good, and been very impressed with the guys at UCSD. I do science and research, and that's what they do.
So the SUV of 6 is kind of borderline, you know. I think they usually, if they want to be sure that there's really a lesion there, they like to see 10 or higher. But, you know, 6 does require further investigation, I would say. John, Vic?
And I'm not real keen on a biopsy. Academically, I am, but a biopsy of your neck, you know, there's risks with everything. But like I said, I'd rather fight all the battles up front so we know the landscape. And my aggressive cancer may well come back, and I'll be in this group in 4 years. I accept that. I would like to treat it well initially, and then take a hiatus during my better years if I can, and come back. And so the radiologist listened to that preference and came up with something he was comfortable with, which I think I am.
So are they going, if he moves to radiation right now, what is the scheme for the radiation? Is he going to radiate all your lymph nodes across your pelvis and also treat the gland? How is he going to treat the gland, and what's he going to do? What's he going to do beyond the gland?
So he has a simulation model. So I will get a high resolution MRI after the points have been set in the gel. My understanding right now is the lymph nodes were negative on the PSMA, so he's going to focus on the prostate and evaluate the seminal vesicles with the more recent MRI. How much of that he does with the seminal vesicles, I don't know. My perception is he won't do more than the prostate in that area.
Okay. Well, if it were me and I had 4+3, and I can't remember, did you have crib reform as well?
Correct.
Or not?
And intraductal.
Yeah, if it were me, and Ben may have some input on the intraductal, but if it were me with intraductal crib reform, seminal vesicle involvement, I would definitely ask to have my whole pelvic girdle radiated and to have focused treatment on the gland. What Mac Roach is doing at UCSF is 2 SBR treatments to the gland, and I think 20 odd IMRT treatments across the pelvic girdle. I would have no doubt in that, and then probably 18 months minimum is what I would want, or maybe even 24 on hormone therapy. The seminal vesicle involvement to me is huge. And I've seen guys be undertreated with seminal vesicle involvement, and it's come back in a really serious way. It seems like it is a very big signal. And a radiation oncologist who doesn't overtreat based on SVI would, for me, demand a second opinion with somebody else. And in your case, I would probably say head up and speak to Percy Lee at Irvine, or City of Hope, or Nagar at UCLA. But I would be very concerned if the limit of my RT treatment was the prostate and the prostate bed and the seminal vesicles.
Okay, fair enough. Other people weighing in? I appreciate you going longer than normal.
Yeah, we have 4 more minutes left, guys, so just saying.
Any differing opinion?
Gary V?
Yeah, my answer is very similar with Rick's, and that's go after it. I did that almost 5 years ago with Dr. Roach, and I'm still alive today as a result of it. You need somebody that's going to aggressively go after it with radiation initially. And that means getting all your pelvic nodes, which Roach did. Roach was way ahead on this. And yeah.
So if I understand you, even though they don't
hold
show
on,
up on...
Hold on a minute. Hold on a minute. I'd like to hear from Ben, because Ben's an introductory person.
Oh, of course, I can't tell you what to do, but I think it's not a good idea to cheap out at this point. People keep trying to play a cancer game, trying to run the numbers on cancer, trying to get ahead of the game, making these kind of arguments. They want to have a good life, even if it's a shorter one. The fact is, if you have crib reform, that's a bad prognosis. And I think you're being foolish. You're overestimating the effect of the side effects. You see the people here, we're not invalids, and you are underestimating the aggressiveness of your cancer. Don't go cheap on this. That's my feeling.
And Ben had crib reform and introductal.
And ductal.
And what?
And ductal. I had everything.
Oh, and ductal. Yes.
And so did I.
Who said that? Oh.
That was Gary that said that.
So just a question, we treat the lymph nodes even though they were not hot on the PSMA.
Yes.
Just
I mean,
because
I had disease that they suspected was outside the gland. Nothing showed up in the lymph nodes at the time. Mac Roach treated me across the pelvic girdle. That was 17 years ago, and God bless him. I just saw him at UCSF, and we had a discussion about a bunch of things, and he walked away, and I said, Mac, thank you. And he looked around. He said, for what? I said, for me being here right now.
You should bear in mind, Wes, that PSMA being negative does not tell you that nothing's there. You have
well, that
you can have
yeah,
you can have micrometastasis, right? That isn't being
that
picked up.
that should be a given. I think it would be anomalous if there weren't someplace given the parameters. I would think whether the body takes care of it or the Lupron takes care of it, that's a separate question. But no, I do understand what you're saying, I believe. So
It's not
anyhow,
an
I
all
appreciate
clear
it.
signal. Yeah.
No, not even. No, it's the best we have. Well, I appreciate it, guys, and your advice has been very enlightening, and the range of personalities and problems you have is breathtaking. I'm still learning. Thank you for the time.
You're welcome. And that is our last caller for tonight. So
Yeah,
good night. Oh yeah, Rick, you wanna?
No, I was just going to say, Larry, in Alaska, we start at 3. We start early on a Tuesday.
Yes, I did mean to say that, and also on Frank Giambra, I'm sorry, you guys, we have a 10-minute cutoff, and you just missed it. Otherwise,
And Larry, I can't read stuff like this during a meeting. If you want to send me a note, feel free. But it's a non-starter. I got to close the room right now and reopen it for MS. Sorry, man. But copy and send it to me, okay?
I don't have your address.
I think it's in the reminder.
I don't get the reminder.
okay, I'm going to turn off the recording in any case.
Thank
Night,
you.
everybody.
Bye.
Thank you very much.
Rick.